My name is Prem Roncorn with the Commons Clinic, and I'm a hip and knee surgeon. I'm really excited to share with you our JBJS article entitled Distinct Three-Dimensional Morphologies of Arthritic Knee Anatomy Exist. CT-based phenotyping offers outlier detection in total knee arthroplasty. First and foremost, thank you so much to my co-authors, especially Josh Wu, who this study couldn't have happened without his diligence. So this study represents 4 years of work, and it starts with acknowledging that there's not much knee replacement surgeons agree upon. We know and recognize that anatomy is king, and we also know that there's a lot of variation in the anatomy that we deal with. It's nothing short of amazing how much 3D anatomy we are taking into account in surgery in real time, but there is room to be even better. And we all have our own preferences with respect to technique, alignment, implants, fixation, adjunctive technology. And it's a very special time in orthopedics where, for once, we have three-dimensional preoperative CT imaging that lets us look at all three planes, coronal, axial, and sagittal, as well as the emergence of AI, which, quite honestly, has not delivered all the major promises it's kept. So we were excited to help contribute in a clinically meaningful way that helps us augment our analyses above what can be expected of human cognition. So if we acknowledge that anatomy is our North Star and arthritic knees are not all the same, how can we even reasonably expect to compare our techniques and technologies, let alone our outcomes? Thus, the purpose of the work was to three-dimensionally phenotype the broad variation of arthritic knee anatomy, to establish a foundational language along the episode of care to compare total knee replacements. Quite frankly, we didn't know what to expect when you look at 27 variables across 1,352 CTs. And we used a spectral clustering algorithm because it accepted the sensory overload and accepted the chaos and acknowledged that asymmetric proportions of populations exist. We were shocked that even when we repeated the analysis, removing variables affected by severe deformity, that there were 4 phenotypes that came through. 2 of them that we termed type 1 and type 3 represent a unique cohort of outliers that have a total of 26% of patients that come in through the door for a knee replacement. These aren't just valgus or female or loose knees. These are patients with real unique parameters that include hip rotation, medial posterior tibial slope, hip knee ankle angle, tibial femoral angle, medial proximal tibial angle, and the lateral distal femoral angle. The other 2 wild type phenotypes were termed type 2 and type 4. They have subtle differences, but they may diverge or may even converge. And there may be further phenotypes that come about as we globalize our data set. Really, unlike prior classifications that look at only the native plane, native anatomy or coronal plane anatomy, or suggest an impractical number of classifications, we really enjoyed this work because it helped simplify three-dimensional anatomy into 4 simple phenotypes. And this could be the building block for a lot more special work where we can contextualize this preoperative type to implant selection, alignment technique, and applied technology. Perhaps with this foundation, we can lead to better pathways and allow for better balancing, more rapid recovery, greater satisfaction, with a more personalized approach that takes into account the uniqueness of each knee.